Hey, my name is Ryan McBain, and I'm a professor at Harvard Medical School and a technical advisor on the ABCM project in conjunction with Brandeis University. Today, I want to take about 30 minutes to discuss insights and use cases from ABCM. I think sometimes conversations about data, analytics, and the like can be overwhelming, and I want to try to break through this noise and explore concrete applications of using ABCM data so it's clear to you how to use these data in your own work. So let's dive right in. The first insight pertains to costs, cost drivers, and budget projections. At a basic level, ABCM data should tell you about costs in the health system. That includes computing average service level costs for different types of encounters. For example, HIV testing and counseling, antiretroviral therapy, and prevention of mother-to-child transmission of HIV. Second, we can take a service level cost like antiretroviral therapy and we can break it down further. What amount of these costs for ART are driven by human resources, space or infrastructure, equipment, or consumables like medicines? And third, we can evaluate measures of central tendency. For example, what is the mean or average value of HIV testing and counseling, as well as measures of dispersion. So how widely does the cost of HIV testing and counseling vary from one person to the next? This is because the costing approach we use for ABCM assigns individual costs for every aspect of individual patients' visits based on the resources they consume. So let's get into some actual cases. In the first case, let's imagine that you're responsible for budget planning in the next fiscal year. What budget do you require to hit new health coverage targets? Well, let's start with the current situation. So right now in our fictitious health system, we have 80% coverage for antiretroviral therapy among stable patients, 70% coverage for antiretroviral therapy among unstable clients, 90% coverage for HIV testing and counseling, and about 85% coverage for PMTCT. We can also see that this is costing us a certain amount of money per year. So, for ART stable, for example, in this first field here in red, we can see that the average cost over the course of a year is about $200. And for 80% coverage, that's reaching about 0.8 million individuals. We could also look at, for example, HIV testing and counseling is about $23 per counseling session, and 90% coverage on that would be reaching 2.9 million individuals. Now, if we look at the table, we can do some basic computations, right? We can multiply the cost per unit from the ABCM data collection by the total number of units, or in this case, the units would be people served. From this, we get total costs, the final column. Ultimately, we come out with a budget of about $346.7 million for direct spending, which is about 70% of the total current budget of $495 million. Okay, so sticking with this use case, what we're really interested in is the cost of care for the new targets. In this case, highlighted in yellow. So, for example, we want to increase ART coverage to 90% for those who are stable, 80% for those who are unstable, increase HIV testing and counseling to 95%, up from 90%, and PMTCT coverage up to 90%. The unit costs for each of these services has also increased slightly from our TD ABC or ABCM data collection values. because we've adjusted for inflation to the new year. So the target coverage levels also mean that we will inflate our number of units, our quantities. For example, on the previous slide, coverage for stable ART was 80% and reached 800,000 people. In the new scenario, we're trying to reach 90% or 900,000 people. Again, multiplying price per unit by quantities of units, we arrive at the total cost of direct services, $417.4 million. Again, if we assume that this represents 70% of the total budget, as it did in the previous year, then our total budget would be $596.3 million. So in summary, we would surmise that expanding to target coverage for the next year would require roughly $70.7 million in additional direct service spend and $30.6 million in indirect costs based on our computations. So let's say that we go to the Ministry of Finance and they look at this and they are not enthusiastic about the newly proposed budget. So instead, let's say that the Ministry of Finance comes back and says, look, we can't give you $596 million, but we can give you $550 million. That could be your total budget. And the following question that would come from that would be, well, what would the revised coverage targets end up looking like if you had a budget cap of $550 million? So in these circumstances, we could work backwards a bit to say, well, 70% for direct services leaves us with $367.5 million, because 70% of $550 million comes out to that. And based on our cost per unit, which we also know, we can try to adjust the number of people who end up being served to generate an alternative calculation for the percent of people who we think can be covered. So, for example, ART coverage might not move from 80% to 90%, it might only increase 2% up to 82%. So, in short, use case 1 draws on the ABCM unit cost data for different types of services, and you can use these individual cost estimates to try to anticipate or project future costs and coverage. So let's look at a second use case here. So in this scenario, you're tasked with answering the following question. What is the magnitude of cost savings achieved by training peer mothers, i.e. local community members, to deliver certain aspects of prevention of mother-to-child transmission in lieu of nurses? So maybe we think, this is a good model. Peer mothers are less expensive, and it would free up time for nurses to provide care elsewhere. So why don't we see if this is true? So PMTCT currently costs $14.60 for the human resources component. So each PMTCT visit includes, for example, 20 minutes of nurse time, as indicated in the table on the left-hand side. And there are a total of 4 sessions, and so that means 20 times 4 is 80 minutes total being used. The capacity cost rate of a nurse, the capacity cost rate being the cost per minute of their time, is roughly 5 cents per minute. So 5 cents per minute times 80 minutes comes out to be $4 of utilized nurse time per individual. So by contrast, peer mothers, the table on the right, we can see nurses now become peer mothers, have a capacity cost rate that's closer to 1 cent per minute. And so the total cost for 80 minutes would be 80 cents, which would be a savings of about $3.20 rather, or a reduction of about 21.9%. So fairly substantial savings. But if we back out of this and put it in context, we actually see that the cost savings are not quite as dramatic as we first imagined. So consumables, for example, as a different aspect of PMTCT costs, were $123 before, and they're going to remain $123 after. If we look at the table here, we can see that the largest contributions here come from the cost of antiretrovirals, about $90, and other pregnancy-related supplements like iron and folic acid. So overall, the reduction is actually more like $150 down to $146.80, which is only a 2.1%, 2.13% savings. So this is actually quite interesting, right? So on the one hand, it's telling us that if we really wanted larger savings for PMTCT, we'd really need to figure out opportunities to reduce prices or waste or improve supply chain, something related to consumables, since that's the largest cost driver. On the other hand, if, say, 300,000 women per year are receiving PMTCT, even a 2.1% savings could be meaningful, right? That comes out to be almost $1 million of savings per year. And it again would free up about 80 minutes of nurse time every time that is redirected to peer mothers. So let's look at a third use case, still focused on the initial insight regarding costs, cost drivers, and budget projections. So here, we're considering establishing a new HIV testing and counseling clinic. In other words, a clinic that only performs this one service line as a way to improve efficiency. So our question here is, what would the projected operating costs of the facility be in the first year? The easy way to answer this question is to look at all the individual components of the data we've collected from our ABCM work. We know the cost of individual consumables, the cost of construction and maintenance of spaces, the cost of human resources, equipment, and indirects. So all of the unit costs and the time estimates are there for the taking. So to pull out this example a bit further, why don't we just look at one dimension of operating costs, specifically human resources. So we have a number of different inputs that we can use from our ABCM data here. As shown in the table, we have information on the salary and fringe benefits for each of the different provider types that we might consider staffing our facility with. So for example, we might know that the typical physician has a salary of about $30,000 per year, as well as fringe benefits of about $7,800. We also know what the capacity of each of these different roles happens to be. So for example, the average physician has about 100,800 minutes per year available to interact with individual patients. So that comes into play when we're making hiring decisions at our new facility. So we've just roughly estimated here in the second column of the table, what would happen if we hired 2 physicians, 4 nurses, 1 receptionist, 2 lab techs, and 2 pharmacy technicians. Well, from a cost perspective, we can do out some very straightforward arithmetic to know that the total cost to employ those individuals would be about $170,100 for the course of an individual year. But let's look below the table on the left-hand side. We can see that a typical HIV testing and counseling visit, based on the data that we collected at facilities, would entail about 5 minutes of physician time, 10 minutes of nurse time, 2 minutes of receptionist time, 10 minutes of a lab tech's time, and about 4 minutes of a pharmacy technician's time, which means that overall the average cost for human resources for an individual visit is about $4.27. Now from this we could ask ourselves, what's the achievable volume that could be reached based on our staffing levels, our theoretical staffing levels from that table here. So again, if we have 5 minutes of physician time for each visit, then we could theoretically serve 40,320 patients. And the way that we would come out with that estimate would be to say, well, we have two physicians. Each physician has 100,800 minutes available, so 2 times 100,800 minutes is 201,600 minutes. Divide that by the 5 minutes per patient, and you come out with roughly 40,000 patients that could be seen. For nurses, it's quite a similar story. About a little bit over 40,000, closer to 44,000 patients could theoretically be seen. And that's because even though nurses are required to spend about twice as much time with each patient, we're hiring twice as many nurses, right? We're hiring 4 rather than 2 in the case of physicians. So the math works out well. But let's look at lab techs, that fourth bullet point here. So for lab tech time, it's 10 minutes. And here we see that the achievable volume is only 22,500 patients. So this is a big problem for us from an efficiency perspective, because now lab techs are going to become the bottleneck at our facility, right? The physicians are going to be moving through patients really quickly, but meanwhile, the lab techs, which we only have hired 2 of, need to spend 10 minutes per patient, and since there are only 2 of them, it's going to slow down the whole process, right? We're going to have a log jam in the laboratory. And on the opposite end of the spectrum, we can see that for receptionists and for those in the pharmacy, they can see well over 50,000 patients. So they're sort of really cranking through, which means that the receptionist is going to have a lot of idle time, right? So, they are going to have patients come through, and the patients are going to end up getting stuck in the laboratory, or there's going to be a line out the door, depending on the circumstances of the facility. And so what we probably would want to do, looking at this picture, is to think about hiring at least a couple additional lab technicians, in which case it would bring up our achievable volume closer to double what is currently available for the lab techs with only 2 of them. So if we hired 4 lab techs instead of 2, we would be able to see about 45,000 patients over the course of the year. Of course, that would also drive up our total costs, right? So if the average lab tech costs about $8,800 and we're hiring 2 more of them, then we would need to come up with an additional $17,600. An alternative would be, maybe we don't need to see 40 or 50,000 patients at our facility because the catchment area that we're operating in is actually really quite small. We think that in a typical year, based on the prevalence of HIV in our community and the catchment area we're serving, that we'll probably only see 20,000 patients. If that's true, then we really don't need this number of physicians or nurses or lab technicians or receptionists that we currently have set up. Now, for receptionists, we already have sort of the minimum, just 1 receptionist who's stationed, and so there's not really much we can do about that, although the receptionist is relatively inexpensive. It just means that the receptionist is probably going to have some idle time during the day waiting for new individuals to show up. But for the other cadres, we could reduce it. We could have, say, 1 physician instead of 2, or 2 nurses instead of 4, and this would lower our costs and also end up with a facility that sort of meets the population needs. So, in summary, the time estimates provided by ABCM allows us to anticipate the potential costs and service volume and to plan for personnel costs and operating costs more generally as a result of that. So let's move on to our second insight here. Let's talk about variation in costs and resource allocation. So first, we can compare service costs and resource utilization, i.e. variation, by regional, facility, and client characteristics. For example, at the regional level, we might examine costs by rurality, region of the country, population density, and the like. At the facility level, This might be the type of facility, for example, public or private, facility subsidies, and level of care, for example, primary, secondary, or tertiary. Lastly, at the client level, this might include client sex, age group, marital status, insurance status, years of education, even client satisfaction, for example. Second, or seen another way, we can view this variation in terms of the outcomes of interest. So, for example, the total service cost, or just the cost associated with a certain aspect of delivery. For example, cost from providers, time interacting with providers. We can also look at time estimates from different vantage points. So, for example, we could compare client wait time, client-provider interaction time, and the like. So in short, there's really a lot that could be explored through these various avenues for this second type of insight. So let's talk about illustrative use case number 4. Let's say that you want to examine whether resources are distributed in a balanced way, distributed fairly and efficiently across facilities, or if instead the allocations appear to be unbalanced and could therefore be corrected. One way to investigate this would be to look at wait times. So, for example, do some facilities have a large bottleneck where patients are waiting for long periods, whereas other types of facilities, patients are being seen in a timely manner? So, running some analyses with our ABCM data, we could, for example, look at average wait time broken down by region of the country for something like antiretroviral therapy. In this case, in this particular graphic of these box plots, we have several regions of the country. We have northern, western, eastern, central, and then the lowest bar box plot has all of them combined together. And what we end up finding is that in the western region of the country, the average wait time is 54 minutes. It's almost an hour long. By comparison, the average wait time in the eastern region of the country is only 9 minutes long, so not even 10 minutes. So it's a six-fold difference between the two regions of the country. So this might be a starting point for further conversation. We say, wow, this is a huge discrepancy. Does this mean, for example, that resources in the western region are not as available as the eastern region? Why is it that patients are waiting so much longer in one part of the country versus another? Let's continue this illustrative use case to talk about another dimension that we could look at. We could look at the overall length of an ART visit broken down by facility level. So here in our scatter plot graph that we have the average total length on the x-axis, and the y-axis we have the different types of facilities. So health center level 2 was sort of the lowest level, like primary care, health center level 3, then 4, then a hospital at the hospital level, and then finally all the different types of facilities combined. Here we see that the visit duration at a lower level health center is only on average about 19 minutes long, but at higher levels of care, the average duration is about 40 minutes long. But there could be a good reason for this, right? So, for example, people who go to a lower level facility, right, the one that's closest to them, they might be less sick, or they have they're a less complicated case. And so this sort of distribution might make sense, right? We would expect that at higher levels of care, people have greater, more complex needs, and so providers are going to need to spend a longer period of time with them. So, the regional variation we saw in wait time on the previous slide might give us pause, whereas something like this result here, we might think actually aligns with our expectations. And of course, there are lots of other lines of inquiry that we could explore that we haven't showcased here, but we could compare public versus private ownership of facilities. We could compare the average cost or resources allocated to men versus to women, even within a particular intervention, and on from there. So let's talk about a fifth illustrative use case for exploring variation. And here we're looking at opportunities to improve efficiency. In this example, we're looking at voluntary medical male circumcision. So let's say you're analyzing the ABCM data and you discover that the cost of VMMC is $18 at one facility, at a Muck Health Center, a level 4 facility, whereas at a different health facility at Mukono-ku Health Clinic, which is also a level 4 facility, it's $47, right? It's more than twice as expensive. So this sort of discrepancy between two facilities might be remarkable enough that we think we should really see what's driving this difference here between the most expensive and the least expensive facility. And so, as a data officer or somebody looking at these data, we might travel to the facilities and figure out what's going on, or call somebody on the phone and ask some questions. And so the answer that we have listed here as an illustration is that at a Muck Health Center, a nurse is performing all of the tasks except for the circumcision. Additionally, clients are required to have an escort to accompany them and take medical supplies so that once the surgery is done, they can immediately leave the facility within maybe 10 minutes of the surgery ending. At Mukono-ku, alternatively, there's a physician who's performing all of the tasks, and clients are put on a 1 to 2 hour bed rest for observation after the completion of the surgery. And so this raises an interesting question, right? Should one of these models be changed to look more like the other? Right? We might say, oh, there are cost savings to be had here if Mukono-ku followed the same model as a Muck Health Center. Or alternatively, if we had a group of experts, they might say, no, we really think given the nature of this particular intervention, it shouldn't be a nurse who performs most of the tasks. So it's really sort of an interesting clinical as well as administrative question here. So let's move on to our third insight area, which has to do with quality of care, and in particular looking at quality of care as exhibited in process maps. So as a reminder for those who aren't familiar, process maps convey who, what, where, and when service delivery occurs. So specifically, we're asking, who are the providers involved in each activity? What are the activities that are involved? Where do these activities take place? When do the activities happen? For example, all of the time or just some of the time, or the sequence, right? What's the typical order of the activities? And then once process maps are complete, we can inspect these process maps to learn if there are opportunities for improvement. We could look within facilities and across patients, or we could look at between facilities to compare facility A versus facility B, for example. We might find differences in the frequency or pattern of activities, the duration of each activity, the cadres involved in those activities, or even the overall costs. So let's look at a couple examples together. So the first is illustrative use case 6 here. So you decide to examine care delivery processes for HIV treatment, ART, at two facilities that have very different costs of care. So in the top diagram, we see that the staff involved include a case manager, highlighted in orange, a counselor in sort of a light pink, a nurse in green. And we could compare this to the bottom figure here, where we see that there's a peer educator performing several steps, represented in sort of a light blue, a clinical officer, which is in a different shade of pink, and again a nurse, which is represented once again in green. So comparing the maps at the top and the bottom, this raises several questions for us. So for example, if we look at step number 2 in the top figure, health education, we see that there's a counselor who's performing this, and the counselor should be performing it for about 25 minutes. That's what that little bubble in the left-hand corner is indicating. If we compare that to the bottom figure, we see that the first step rather than the second is health education. It actually happens before registration. The target duration is 45 minutes, so it's a very long health education session, and it's done by a peer educator instead of a case manager. And then for the consultation component, which in the top figure is represented by step number 4, we can see that this consultation happens every visit, and it's done by a nurse, and the target duration is 30 minutes, although that's what's represented in the bottom left-hand bubble, but it typically actually lasts for 20 minutes. That's what's shown in the bottom right-hand bubble. And we could compare this to what we see in the bottom graph here, which is that in the bottom graph, consultations actually skipped over half of the time. 55% of the time, there's no consultation. In the remaining minority of the time, the 45%, the individual meets with a clinical officer, which lasts a shorter period here, only 10 minutes, rather than the meeting with a nurse that happens every time at the other facility for 20 minutes. So these are competing models that we could raise and maybe standardize over time if we thought that there was an opportunity to do so. If we thought that one model was better than another, we could try to enforce this. So let's try another. So in this case, you decide to compare HIV testing and counseling processes across facilities to establish a default model. So here are the types of questions you might ask would be in terms of patient education. Should patient education be done while waiting with a peer educator, as in the bottom figure, or with a nurse in a separate room in the top figure? Or for the various steps 3, 4, and 5, which include testing, meds dispensing, and consultation, should we always have testing and meds dispensed in standardized locations with standardized cadres? So for example, meds dispensing always happens in the pharmacy with a pharmacist, and testing always happens in the laboratory with a lab technician. Or, as in the bottom figure, might we consider combining those so that the testing, the meds dispensing, and the consultation all happen by a nurse in the pre-consultation room? So in summary, process maps provide a visual model for how care can be delivered, and we can inspect these process maps to decide whether we like what we see, or if we see problems that need to be fixed or opportunities for greater efficiency. So the final insight number 4, pertains to health system redesign and projecting costs from this. So to the extent that process maps do indeed represent care delivery, we could redesign process maps and therefore care delivery and ultimately compute corresponding costs in something like an Excel framework. This would allow us to sort of create a reimagined health system, and computations can be used to project future costs, coverage, and outcomes. So let's return to the last set of process maps that we discussed for HIV testing and counseling. So here we have clients who have, following through this process map, a 2-minute first step, as indicated by the little orange bubble in the bottom right-hand side of this box, for a patient registration with an archivist. After that, they move to patient education in a pre-consultation room with a nurse for 5 minutes, followed by laboratory testing for 5 minutes. And then if they test positive, they'd go to the pharmacy to have meds dispensed for 5 minutes where they meet with a pharmacist, and lastly go back to the consultation room, meet with a clinical officer for 3 minutes. So This process map can be represented computationally in the Excel table below as well. So looking just at the first row as an example, we see registration, which happens 100% of the time and occurs with an archivist whose capacity cost rate is 2.3 cents per minute. And this happens in a waiting area, which has its own cost per minute, capacity cost rate of about 0.2 of a cent per minute. And a computer is used and, again, has its own capacity cost rate associated with it. And we can see ultimately there are 5 steps: registration, education, testing, meds dispensed, and consultation. And looking at these 5 different steps, we can also see the costs and computations related to indirect costs and the capacity cost rate associated with it, consumables, and then ultimately the total cost across all of these different resources. So the final cost associated with this care delivery process is $2.15. Now, why is it $2.15 if just looking at the meds dispensed row, we can see that already costs over $13? Well, the answer to that is that the final cost is represented by the cost of each activity, but then multiplied by the probability that that activity occurs. So for example, medicines being dispensed only happens 5% of the time, and so the actual expected value is 5% times $13 and change, coming out to be about 65 cents. So in summary, this is sort of a way of showing that the computations that underlie the process maps can get us to a final cost estimate. Now let's say that we think we can do better than the workflow here, right? We think we can make a workflow that's more efficient, maybe better for patients, at a minimum by having their time in the facility be shorter, therefore more efficient, more timely, and hopefully the patient's happier. So that could be represented by the alternative process map that we talked about, which is represented here in the top right-hand corner. So in this case, the first step is the same, right? So the patient shows up, they go to a waiting room, they have patient registration with an archivist that lasts for 2 minutes. But things begin to change at step number 2. So in step number 2, we now have patient education happening in a waiting area with a peer educator, rather than with a nurse in a pre-consultation room. So the service lasts a little bit longer, and it's with somebody who is a little bit less expensive. And then steps 3, 4, and 5 all happen with a nurse in a pre-consultation room, rather than the patient moving from one location to the next, interacting with different folks. And so there are also some potential cost savings here because the pre-consultation room is a little bit less expensive than the pharmacy or the lab space, and it doesn't involve a clinical officer who can typically be quite expensive. And so computationally in our table, the activities, the first column is the same, the durations are the same, the probabilities are the same, but what has changed is column number 4. So we see that we've done some task shifting for personnel to lower level personnel to save some money, and we also stay in the same pre-consultation room for the space, rather than moving to different locations over time. And so the upshot of this is that we have a longer patient education experience, a shorter client wait time, the clinical officer has more time to be able to direct to other activities or other interventions, and we have roughly 8% savings. So if a facility administered 50,000 tests per year, that would be about $9,000 of savings for that one facility, essentially by improving the care delivery model, which could be quite exciting. So hopefully at this point you have a good sense of the types of insights that can be offered by the ABCM data. And even though we've walked through a variety of scenarios, you might have some ideas on your own or questions as well. If you do have questions, I'd love to hear from you. You can shoot me an email. My email is rmcbain@mail.harvard.edu, as shown in the second bullet point. So please reach out, and thank you for your time.